My name is Matt O'Malley. I'm the District 6 City Councilor as well as the Chair of the Boston City Council's Committee on Healthy Women, Families, and Communities. We are here today to discuss docket number 0396 in order for a hearing on Black maternal health, racial and gender equity in the healthcare system in the City of Boston. This hearing order was written by myself as well as City Councilor Kim Janey, and I want to thank Councilor Janey for her unwavering leadership and partnership on this hearing, as well as all the incredible work she has done and will continue to do on ending the racial and gender equity gap in the City of Boston. The hearing today will use an intersectional lens to discuss healthcare issues specifically impacting Black women. The epidemic of maternal mortality and morbidity for Black mothers has become an issue that is pervasive throughout the country. For Black women who are affected by structural inequality, the chronic stress of poverty and racism has been shown to have a deleterious effect on health outcomes and is linked to persistent maternal health disparities. The lack of trust and sense of fear is validated considering the data. The United States has the highest rate of deaths from any cause related to or aggravated by pregnancy compared to any other developed country. For Black women, the maternal mortality rate is 40 deaths per 100,000 births compared to 12.4 deaths per 100,000 births for white women. I'm going to repeat that statistic because it is absolutely terrifying. For Black women, the maternal mortality rate is 40 deaths per 100,000 births compared to just under 12.5 deaths per 100,000 births for white counterparts. Massachusetts, like with many policy issues such as gun reform and education, does lead nationally in maternal health. Yet there are the same type of disparities in our state and in our city, especially when it comes to access to services. The Massachusetts State Health Assessment states that Black mothers continue to have the least access to prenatal care. The number of Black mothers suffering from the symptoms of postpartum depression is 3 times higher than for white mothers in Massachusetts. We have some great anchor institutions. We have a plethora of hospitals and universities. We have other educational resources and research resources to address this problem. I'm really looking forward to this hearing from our panelists of experts to introduce the conversation, share best practices, and discuss our next steps. This obviously is an incredibly important issue, an incredibly timely issue, and I'm once again delighted to have partnered with Councilor Kim Janey on this so that we can truly address some of the structural indices which have caused this and solved this very real problem. We're also joined by Councilor Ed Flynn, and after we have the Council's opening statements, thank you, Councilor Nisa Asabi-George, who has joined us as well as an at-large City Councilor. Representative Liz Miranda from the 5th Suffolk District will be offering first testimony before we get to our panelists. But I'd first like to start with Councilor Kim Janey.
Thank you so much, Mr. Chair. I am very grateful for the opportunity to partner with you on this very important issue. I appreciate your leadership. Thank you, Councilor Flynn and Asabi-George, for being here as well as Representative Liz Miranda. You've heard the stats, very staggering stats here. I'm thinking back to when you and I introduced this hearing order. It was at the end of February, and the City Council was celebrating Black History Month, and for this particular year, we were celebrating Black women and Black Girl Magic, and I remember thinking at that time that so many of us as Black women have to kind of power through whatever we're going through. We have to keep going if we're feeling pain, if we're feeling tired, because everything rests on our shoulders. So many of us are heads of our own households, and even myself personally, I've said several times, I don't have time to be sick. I don't have time to be sick, and I will just keep going and keep going. And I bring that story up because we refer to ourselves as being magic, and we are magic, and it's wonderful. But we often kind of take on the attributes of being superhuman, and it's important that we recognize that we have to take care of ourselves and make sure that we are getting the care that we need and that we are speaking up. Equally important, and that is in no way to say that these stats are that we're blaming Black women at all, but equally and more important, we need to make sure that our healthcare providers are listening to us when we bring up these issues around pain or stress or trauma or whatever the issue may be. And so I'm grateful for the opportunity to partner with you and to hear from our expert panel and those who are here to offer expert testimony so that we can truly understand the underlying causes of these disparities that we see when it comes to Black maternal health. And I'm really hopeful that we will really look at the intersections of gender and race and class to really peel back the onion and offer new strategies for moving forward so that we can begin to close these gaps. So again, I'm grateful for your partnership and your leadership. Thank you so much.
Thank you, Councillor Janey. Councillor Flynn?
Thank you, Councillor O'Malley, and thank you, Councillor Janey, for your important work on this issue. Both of you have been real leaders on the City Council on issues that are impacting the most vulnerable in our society. I also had the opportunity to read the statement from a previous statement from Congresswoman Presley and Representative Liz Miranda, and I would like to acknowledge their excellent work as well on public health and maternal health related issues in the African American community. We talked about bias and stereotypes that impact how healthcare providers treat their patients and how health providers put various assumptions on people of color. And that leads to healthcare inequalities, like the high mortality rate for Black women compared to white women. I'm also interested to learn about the strategies and changes that we can use in addressing these disparities in Black maternal health, whether it's addressing structural factors like racial bias in framing policies through the lens of racial justice, as Councilor Janey mentioned, or addressing the service side of this issues like engaging the community. I'm eager to learn about this important issue, prenatal care, postpartum depression, how it ties into the larger issue of public health. We recently had a hearing this morning on a similar issue as it relates to public health in communities of color, and it was an informative hearing, and we learned a lot from the experts that testified. And you know, the more you're exposed to this issue, the more you learn, and the better elected officials we are, because we're able to more effectively represent our constituents when we observe more of this information. So I just want to say thank you to Councilor Janey and Councilor O'Malley for their dedication and their tireless work on this important issue. Thank you, Mr. Chairman.
Thank you, Councilor Flynn. Councilor Saibi George?
Thank you, Chair, and I appreciate the sponsors, the lead sponsors, and their effort. And on this behalf, I just want to reiterate and applaud and lift up this effort to make sure that all of our residents, especially women of color, are getting access to not just appropriate physical health care, but mental health care. I know that across some of my work through my Committee on Homelessness, Mental Health, and Recovery, that access to mental health care is really has a tremendous impact on one's physical health care, especially as we talk about the rates of depression and postpartum depression in particular through this hearing order. And I want to make sure that we also appreciate when there is a mental health crisis, the toxicity it creates within for that woman, for that mother, but also for the family, and the impact it has on infant mental health issues, which we know are a real thing. So I just want to lift that up. I want to applaud this effort and look forward to hearing the presentations from the panelists today.
Thank you, Councilor Saibi George. Appreciate your comments and your great work as well. Some brief housekeeping. First, her name was mentioned, and I would like to echo and thank our predecessor and our Congresswoman Ayanna Pressley, who actually founded the Committee on Healthy Women, Families, and Communities upon her election to the Council back in 2010, or her joining the Council in 2010. I was proud to have been her Vice Chair for the last number of years, and I've since succeeded as Chairman when she left us for Washington, D.C., but this has been an issue that she's been working on and focused on at the local level, and luckily for us has been taking that same fight and focus at the federal level as well. This is a public hearing, and it is being recorded and broadcast on cable television, as well as being live streamed on the city's website. We ask all folks to please silence your cell phones and other devices if you'd like to have some conversations. The acoustics aren't great, so we'd ask you just to please step outside. If anyone would like to testify that hasn't either submitted testimony or will be on our subsequent panel, there is a sign-up sheet to my left at the back, close to the entrance. Please sign up. We will stay here for as long as it takes. And finally, I have a letter from Council President Andrea Campbell, in which she offers regrets that she cannot attend today's hearing. Obviously, she cares very deeply about this issue and wants to thank our sponsors for bringing the issue forward, and has sent a staff to review the committee's report while working on any recommended next steps. So having said that, I'd like to invite Representative Liz Miranda from the 5th Suffolk District to please join us and offer some testimony, and I'm sure she will reference. You can come up to the desk if you'd like, Representative. You can come right up here.
Right here, or can I get this?
Oh, you can sit. You can, if why don't you come? Thank you. Yeah.
Not my chamber.
Quite all right.
It's all right.
You have a much nicer chamber, but we have more people working on a Friday, so I'll take that in the legislature.
Funny.
Present company excluded, of course.
Yes. Good afternoon, everyone. It's quite an honor to be here in City Council chamber with my colleagues. Do we have a time limit?
You don't,
Oh,
Representative.
great. Okay.
As the earlier panel will show, I don't use the gavel that often, so
Okay, great.
go for it.
I'm going to start off before I read my remarks with 3 quick stories of how I got to this work. I was elected in November of 2018, so I've been serving for 10 months as the state representative of the 5th Suffolk. It is my home. It's where I've lived my entire life. And when I got elected, I knew that I wanted to work on issues that were deeply impacting my community. And so I came to this work really thinking about gun violence, immigration rights, and other issues of concern in the criminal justice system. My first week on the job, I got a presentation from March of Dimes, which essentially told me that there was a crisis, and it was particularly impacting my community. And we looked at a bunch of zip codes, and it brought down my heart when I looked at most of the zip codes were in my community. And I said, as one of only 3 black women in the entire legislature of 200 members, that I cannot not stand for us, right? So this is an issue that I champion. Secondly, through this work, often we respond to our traumas in our lives and understanding that part of this work is I watched my sister give birth to a 21-week baby that did not survive, and had my best friend hire a doula in her last trimester because of complications and stress. And so I have been around this issue both personally and professionally, and it draws me here today to testify. Dear honorable colleagues on the Committee of Healthy Women, Families, and Communities, my name is Liz Miranda, State Representative for the 5th Suffolk. Again, one of only 3 black women out of 200 seats, and I think that's an important thing to note, because where we're not represented, sometimes we're not often discussed or paid attention to. It is critically important that I am an advocate for maternal health and justice, an issue that has been negatively impacting this country, this state, and women in my community. My district contains the 3rd most diverse zip codes in the country and is the most minority district in the entire Commonwealth, with 94% people of color. Although it's rich in diversity, it is also one of the poorest, one of the most under-resourced and underserved communities, with a median annual income of about $24,000. And the life expectancy of my dear Roxbury is 30 years shorter in comparison to that of Beacon Street in the Back Bay, just a few stops away on the #1 bus. And that has been unacceptable. As my district is pulling itself out of the ashes of decades of poverty, housing segregation, food insecurity, environmental injustice, and lack of access to quality health care facilities, it also has been confronted by yet another public health crisis, the maternal and infant mortality for black and brown and low-income mothers. All of these systemic issues that have imposed significant burdens and trauma on pregnant women throughout their birthing journey has led me to understand the issue more deeply. Our zip codes are literally killing us, causing us to have more unnecessary C-sections, having later term birth, underweight children, and have led to high rates of infant mortality. Research on maternal health has focused on bandaging the effects and focusing on individual women's actions rather than addressing the larger systemic problem, which is racism, which has led this research and will continue to do so if institutions like government, which we both serve in, are not held accountable. Black women, as stated earlier, are dying at an alarming rate of 4 times the rate of white women during their birthing journeys, and in some cities across the country, it is high as 8 times. As former Bureau Director Dr. Deborah Allen stated in a report, medical conditions alone cannot explain these inequities. It's partly a matter of poverty. When women are poor, they can't buy good food, live in warm and welcoming homes, get enough of the right kinds of exercise, and feel safe when they are out and about. And all of these factors impact the women, and during pregnancy and their babies. She wrote, "This calls for access to high-quality health care and special programs to support women at risk." In Boston, and specifically many of the zip codes in my district, according to the 2016-2017 Health of Boston report by the Boston Public Health Commission, racial groups in Boston experience inequities in a number of outcomes. In 2015, Asian, Black, and Latino females gave birth to higher percentages of lower weight babies at 10%, 12%, and 9% respectively than white females, which were at 6%. Low birth weight babies percentages in Boston were 8.6%, were higher than the state average of 7.5%. Furthermore, Black and Latino females had higher percentages of preterm births at 11% and 10% respectively, compared that with white females at 8%. Again, prematurity percentages in Boston were 9.5%, were higher than the state average in percentage of 8.4%. Finally, the infant mortality rates for Black infants, 8.1, and Latino infants, 9.8, were higher than that of white infants at 1.7. And I described this in my own hearing, that imagine one white child dying and then realizing that 8 and 9 Black and Latino babies are also dying at the same time. And that visual was an important visual to state, and I wanted to reiterate it today. For those reasons, it's why it's been important and critical and necessary that as the woman that I am in the House of Representatives, I have filed a trio of 3 bills, one on racial disparities in maternal care, one on doula legislation through Medicaid, and another on an infant mortality review for the city of Boston. I also have now become a new commissioner on the Ellen Story Commission for Postpartum Depression, because we understand, those of us in this work, that this is a continuum of care issue. So it goes from pregnancy all the way to postpartum time. According to Listening to Mothers, a survey of nationally representative sample of U.S. women, 39% of Black non-Hispanic mothers, 30% of Hispanic mothers, and 22% of white non-Hispanic mothers did not use a doula, but had a clear understanding of doula care and would have liked to have had that care. This difference across races is significant. Furthermore, when looking at payer source, 36% of mothers on Medicaid or CHIP had never heard of a doula, compared to that of 19% of mothers on private insurance. This difference across payer is also significant. Both of these findings show that there are clear disparities in access to knowledge of doula by race and ethnicity, but also by who their insurance provider is. Access to doula care is such a program and a beginning of filling in the gaps of needed policy for access and better outcomes in maternal and child health in our Commonwealth. Doulas address the social determinants of health. They also provide social support to women and help improve communication between low-income and racially diverse pregnant women and their health care providers. Women of color are at the most risk of poor outcomes, yet have the least access to doula care, and this must change. My trio of bills will help to save the lives of moms and babies who look like me, will improve access to affordable care, and improve the birthing journeys of many families. This alone, however, is not enough to tackle the maternal justice crisis in Massachusetts, as government branches need to work collaboratively, and that's why I'm here today. That's why I also support Congresswoman Ayanna Pressley's Mommy's Act at the federal level, which expands Medicaid coverage to include more maternal health services. I don't want to die. I want any of the women in our state, city, or my neighborhood to die while giving birth, or to die because we as public officials and leaders of this city and great Commonwealth didn't listen and didn't do something. Didn't make access to care affordable, and didn't change how we're providing care to our most vulnerable citizens. I'm a Black woman from an immigrant family and from a poor community. but also I am an elected official. I feel an immense responsibility to our constituents, the women of the Commonwealth. I want us to have a fighting chance. We can do that in Boston. We can do that in Massachusetts. We have the chance to be the state in the nation with the most comprehensive maternal justice legislation from city to federal level and supporting other important legislation on racial disparities and postpartum recovery. To close, I'm also proud that we as a Commonwealth have committed $500,000 to the Health Policy Center in this year's budget to study this crisis. However, we can and should do more. That is why I'm here today to say to my city colleagues that I am a partner in working with you to address the issues of maternal injustice happening in our city and our Commonwealth. And I want everyone to remember that every mother counts. Thank you.
Thank you, Representative. Appreciate your terrific work, advocacy, and being with us this afternoon.
Thank you.
Any questions from my colleagues for Representative Miranda?
Thank you.
Thank you.
Thank you very much.
Have a good day.
Thank you. I'd like to ask our panelists to now please join us at the dais. Monica Valdez-Lupi, Executive Director of the Boston Public Health Commission. Dr. Jeanette Callahan, Clinical Instructor in Pediatrics. Okay. Dr. Robin Reed, Assistant Professor of Tufts University School of Medicine and co-founder and president of the Collaborative. And is Dr. Audra Meadows with us as well from Brigham and Women's Hospital? Okay. Well, when she gets here, well, absolutely. Thank you. So I guess it's just Monica Valdez-Lupi and Dr. Robin Reed, if you wouldn't mind joining us, please. And is there anyone else that... Okay. So we believe Dr. Callahan may be joining us, so if she does indeed join us, she will join the panel, similarly with Dr. Meadows, who is en route. There's also some testimony that's been submitted from the Bay State Birth Coalition. Emily Anesta, Joanne Rory, Judy Nursigian, and Eugene DeClerc, Dr. DeClerc, which we will make sure every member of the committee receives, as well as testimony submitted by Dr. Reed, who we will hear from presently, and Dr. Nadiamaka Amute Onugaga from Tufts University has submitted some testimony as well, which we will share with all members of the committee. Monica, thank you for joining us again. Executive Director Valdez-Lupi, you were with us for a terrific and informative and not dissimilar hearing earlier, but we look forward to you opening it up before we get to Dr. Reed for an opening statement. So, welcome.
Great. And it's now good afternoon.
Good afternoon, excuse me.
Good afternoon, Chairman O'Malley, and thank you for inviting us to be part of this important discussion and to join this panel. And I want to also thank Councilor Janey for co-sponsoring this hearing, and also Councilors Flynn and Asabi George for your leadership on a lot of the racial justice, health equity issues across the different work that we do under Mayor Walsh and his administration. Again, my name is Monica Valdez-Lupi, and I'm the Executive Director of the Boston Public Health Commission. At the Commission, we're committed to promoting maternal health and creating equal opportunities for families to have healthy, happy babies. And this is part of our larger mission, which is to protect and promote the health of all Boston residents, especially those who are most vulnerable. We work to improve maternal and infant health through several of our programs that strengthen the natural assets of mothers, their families, and their communities overall. Our programs primarily sit within our Child and Adolescent Family Health Bureau, which is led by Ann McHugh, and they provide direct services and address the different social determinants of health that put mothers of color in the city at higher risk for poor health outcomes. We measure maternal health by looking at several different data points. And thank you, Representative Miranda. Thank you for the water, Counselor, for referencing our Health of Boston report. We have an entire chapter dedicated to maternal child health. And there are a couple of different data indicators that I just wanted to highlight for the counselors that we look at when we're analyzing and considering maternal health. The first is around infant mortality, and infant mortality rate in particular, because we know that this is a key marker for maternal and child health that has been used to gauge social and economic progress both here in the U.S. And abroad, and as well to gauge the effectiveness of the healthcare system. The second data point that we look at is around maternal mortality rates, which are also known as pregnancy-related mortality rates. We refer to maternal deaths, these tragedies, as sentinel events, and we understand that there are many root causes that affect both the infant mortality rate and maternal mortality rate, and that it's all very interconnected. Nationally, the infant mortality rate in 2017 was 5.8 per 1,000, while Massachusetts it was 3.7. The state, the Commonwealth, is a leader in addressing infant mortality rates. In Boston, it was 4.5. Significant inequities, though, and we talked about it this morning, exist in infant mortality rate across racial and ethnic groups, both nationally, across the state, and in the city. In the city in 2017, so this is an update from some of the data that Rep. Miranda had shared, white infants in Boston had an infant mortality rate of 1.8 per 1,000, while that of black infants was 8.2 per 1,000, which is more than a fourfold difference. Despite this significant disparity, we have seen progress in the city, where the mortality rate for black infants in Boston decreased by 35.3% between 2006 and 2017. We've looked at maternal mortality among Boston residents and found that there were few cases over time. So in looking at a 17-year period from 1999 to 2015, there were a total of 10 maternal deaths in Boston, and 3 of these were among black mothers. Other important markers of maternal health include the preterm birth rates and low birth weights, where we continue to see persistent racial gaps in the city. We also continue to grapple with the causes. Why is this happening in terms of persistent racial inequities? We talked earlier this morning about the fact that in the city and in the Commonwealth, we have near universal health insurance coverage and multiple access points in the city through our hospitals and community health centers. But we know that socioeconomic and environmental factors play a huge role in a woman's ability to have a healthy pregnancy and healthy outcomes for her baby. Racism and the experience of discrimination results in toxic stress, and evidence shows that this type of chronic exposure to stress leads to physiological changes during a woman's pregnancy that can be really detrimental to not only the mom's health, but for the healthy development of her child. For Black, pregnant, and postpartum mothers and their infants, we have been longstanding grantee for the Healthy Start Initiative, which is funding that we receive from the Federal Health Resources and Services Administration. And the funding supports our overarching goal of reducing the racial and ethnic inequities in infant mortality, and specifically focusing on the gaps between Black infant and white infant death in their first year of life. Our service area for this grant includes our neighborhoods of Roxbury, Dorchester, Hyde Park, and Mattapan, where the Black infant mortality rate is 10.3 per 1,000. Through Healthy Start, we fund case managers that are called our family partners, and they're embedded across several community health centers. In this year alone, we expect to serve 600 pregnant, postpartum, and interconceptional women and their infants. Another program that we run out of the Child, Adolescent, Family Health Bureau, which supports the Healthy Start Grant, is our Father Friendly Initiative. And this is important because we know that dads need support and resources and services as well to ensure that they remain engaged and connected to mothers, their children, and their families and communities. And so this is something that we've had longstanding in the Health Commission to complement the work of the Healthy Start Initiative. Another program that we fund that also complements the federal resources, we have city resources for our Healthy Baby, Healthy Child initiative. So this program is a home visiting program that provides services through public health nurses, social workers, and public health advocates who go to women's homes to visit them while they're pregnant, after they've had their child, and young parenting families to provide a range of different support services and resources. As part of the Healthy Start Initiative, we also, something that's very important to our work at the Commission is around community engagement. So we have a community action network that brings together clients, residents, and advocates and health professionals to work collaboratively on larger systems issues that impact infant mortality and maternal health. So in this last session, with Mayor Walsh's support, we filed, and with the CAN, the Community Action Network, we were able to introduce a bill that would support fetal infant mortality reviews, or the FEMRs, in Massachusetts. So having this system or this process in place would allow a community-driven confidential case reviews of the cause of individual infant deaths to help communities understand what were the underlying causes and factors so that we can work to address and advocate for policies and systems change at the local level. So we're working hard with the mayor's office to continue to push and move this legislation forward. I talked earlier this morning, or today, about the partnership we have with the Boston Housing Authority, and that program was started with Director McGonigal, and that's the Healthy Start in Housing program. So this has been a 7-year partnership with them that has allowed us to work with pregnant women who are homeless or at risk of becoming homeless to have expedited access to BHA housing. BHA has dedicated 75 housing units for this program, and including 5 that are set aside for custodial fathers with children under the age of 5. Finally, in terms of preconceptual health, we need to and continue to provide overall wellness services and help and support to women to access comprehensive reproductive health services, because we know that's important for overall maternal health. We also have school-based health centers that are embedded in our high schools that provide support service for young women at 6 Boston high schools, and these are public health nurses and health educators that, again, are providing information and resources around contraception and reproductive health. So in closing, I want to thank the counselors again for allowing us the opportunity to share what we've been doing at the Commission, and we're really looking forward to working with you in the upcoming year to address and hopefully improve the data that we're seeing in terms of inequities in maternal health.
Thank you, Executive Director Valdez-Lupi. Appreciate your great work and leadership on this. Dr. Reed, welcome.
Thank you. Good afternoon, everybody. Chair Mr. O'Malley, Ms. Janey, and other members of the Council, thank you for this opportunity to speak in favor of this hearing on Black maternal health and improving equity for the residents of Boston. The Wellness Collaborative, which I represent, is an interdisciplinary nonprofit Black think tank and education organization co-founded by 3 Black women, Jeanette Callahan, a pediatrician, Karen Craddock, an applied psychologist, and myself, an internist. The Wellness Collaborative is engaged in promoting health and wellness for our communities. We have had the good fortune to have Councilwoman Janey speak to us on this particular topic in April of this year at our Reimagining Healthcare Forum entitled Maternal Wellness, a Conversation with Our Brothers and Sisters. Massachusetts has long had a maternal mortality and morbidity review committee, and with improved surveillance and assessment, action has been taken to decrease overall rates of death and disability for mothers and children. However, gaps between whites and blacks remain. Today's focus is about reviews, reporting, and remediation that are needed to close the gap. Women over the age of 35 and those under 30 are at 2 to 3 times higher risk than white women. I would like to speak to the latter, young women. Young women less than 30, those on public insurance, and those with less formal education and more social strains are prone to poorer outcomes and higher rates of depression and domestic injury. We also know that these young women are more likely to have preventable medical causes of mortality. Why is that? Providers have been known to make assumptions about their patients, whether it is women in heart attacks or blacks in pain tolerance. Here, the assumption may be that a young person has no troubles, is healthy, needs nothing, and can just push it out. But this is an antiquated myth. perhaps rooted in a history of enslavement of African people here in America. The psychosocial stressors of marginalization have an impact on Black women, prenatal, peripartum, and parenting. It is time to understand that young Black women need to be supported, assessed fully for risks, provided appropriate medical monitoring, and educated. But we can only do that with a system and providers that vow to provide trustworthy caring and be accountable for shortfalls. At our April forum held in Roxbury, we learned through discussion and a survey that Black men want to be welcomed into the discussion, care and support of maternal and child health from before conception to after, regardless of marital status, and respected for their status as father. We learned that change requires breaking the silence about current systems and welcoming co-creation of a new model of maternal care and caring that includes community. A suggestion was made to rename postpartum depression as peripartum depression, which requires early recognition and action, including the 90 days postpartum. This includes obstetricians and PCPs for action, as they are having the most frequent contact with the mother. Rather than assuming mommy bliss, evaluating for depression should be routine at every pregnancy visit, just as asking about safety at home has become routine during every annual physical exam. History of adverse experience in treatment and discounted preferences, both next door and across the media, have created an environment of distrust. Most individuals support the creation of a community-sited birthing center with high-quality care and safety, cultural relevance, and affiliation with more than one medical center. Consideration should be given for both an independent center or a joint venture between medical centers. Insurance coverage of doula services to help shepherd a woman through the unknowns and stresses of childbearing are strongly recommended. Studies have shown that incorporating doulas not only increases patient satisfaction, but also reduces the frequency of cesarean sections and reduces costs by close to $1,000 per live birth. This was published in Birth in 2016. A community advisory panel should be developed to examine next steps and to support institutional plans for advancements, whether conducted at the level of the Public Health Commission or at the level of each healthcare facility, with a report out to the mayor and the council within 1 to 2 years. The city can commission their own advisory community panel for research or use existing structures for providing community advisory panels for research and investigation, such as CHAIRS, the Center for Community Health Education, Research and Service. Again, I thank you for this opportunity to speak to the City Council on this very important topic.
Thank you very much, Dr. Reed, and thank you, Executive Director Valdez-Lupi. I will begin just briefly. Monica, you had talked about the stats in Boston are quite better than the rest of the country. We lead in many metrics, but I guess, and this is open to both of you, are there certain programs or early screening or outreach that is happening in other cities that maybe we ought to emulate here, or some best practices? I'm sure there are best practices that other cities could look to us for, but are there other things that we ought to be considering, to either of your knowledge?
I mean, I can start that I know from work that I did before coming back to Boston. I worked at the Association of State and Territorial Health Officials. We were partnering with HRSA at the time and March of Dimes, and some of our colleagues in the southeastern states, because they have dramatically higher infant mortality rates, had used models where they had group prenatal visits. I think there might be a few health centers in this city, and I don't know, Dr. Reed, if you're familiar with that model and if there are, but I think there might be. I know that.
So talk that through. So a group prenatal visit?
Right, as opposed to the usual model where it's a one-on-one, either with an OBGYN or a nurse practitioner, if that's what we're looking at, that clinical model where women who are generally at the same stage of pregnancy go into their prenatal visits together as a group, and that way they are their own cohort of sorts that they can talk with each other. There's a shared experience, and there's that peer-to-peer interaction. So I know that that's something that our colleagues at the Association of Maternal Child Health Programs, AMCHIP, has also written about as an innovative model that other places are using.
Dr. Meadows may be able to speak more to it when she arrives, but certainly group activities help people feel less isolated and less alone in the experience. So it is a great idea to consider that kind of a model. And I don't know where around the city they're doing that at this point.
That sounds like a great, just thinking in part of my district in the Mildred Haley Housing Development, there's a very vibrant and active mothers group, and it would seem a great opportunity. I mean, there are 800 families that live in those buildings to sort of, better connect and work and build that community sense for those. Do we offer discounted prenatal vitamins as a city resource? Is that something we could do? They're quite expensive.
They're usually covered by health insurance.
Oh, health insurance does
Yeah.
cover them? Okay.
We can double check if, for the Mass Health clients, but I suspect that that is probably a covered prescription.
That's great.
But we can double check and confirm.
Okay. And this is sort of an open-ended question, and then I'll turn to my co-sponsor, but what would either of you or both of you envision for a more equitable maternal health care system? What are some things, we just identified one or two sort of best practices, but what's something that is just shooting for the stars that we ought to be figuring out how we can leverage the resources with the best health care system in the country in our backyard, but to better address these issues of sort of systemic inequality and divergent disparities?
I would say doulas is probably low-hanging fruit, actually. That if that were covered by health insurance, it would be something that would be available to all and could provide more comfort in trust and communication, where people may feel inhibited in speaking up themselves or sharing feelings of feeling sad or depressed. The doula can help bridge that. So I think that would be very cost-effective.
Absolutely. That's great. Monica?
I also think that in talking with the staff, sort of those additional supports like childcare and transportation, all these things that make it easier for families to living wages to just improve overall, not necessarily within a specific city agency, but certainly we talked this morning about those larger societal barriers and these structural barriers that have created the conditions where it's hard to, be a Black woman. And we talked about some of the data. Dr. Betancourt was talking about some of the data this morning in terms of just controlling for socioeconomic factors, just being marginalized and experiencing toxic stress. It just it's not a level playing field for Black women. And so if there were other things that we could think of that would provide additional supports, I think those would be opportunities, not necessarily low-hanging fruit, but definitely important to address overall health.
Okay, great. And is the same sort of disparities evident in miscarriages among Black women as opposed to white counterparts, or is that data not?
My sense is it's the same, but I couldn't quote
More
exact
curious.
figures, yeah.
Okay. Thank you both. That's all I have for this first round. Councilor Janey?
Thank you so much. I'd like to come back to the group appointment suggestion. That is a best practice. Where are we seeing that?
I can get you, but I seem to recall these were in some of our southeastern states when I was working with our association, but we can get that for you.
Yeah. I think it would be something that we may really want to explore as a strategy here. One of the things that I think we need to recognize and lift up is the social capital that many folks may not have the same kind of social capital that some of their white counterparts have. And so when you create these kind of opportunities for group bonding and sharing of stories and questions, for their doctors, there's kind of a strength in numbers. So it could help us building the social capital and understanding more the types of questions we need to be asking our doctors. One thing that I always find interesting when I just talk to people in my own personal circle, and I know that this is a challenge, and I'll just speak from my own personal experience as a Black woman, it was probably not until I was in my 30s where I really kind of took control of my own health care and understood the importance of being my own advocate. Before that time, it was the doctor knows best, and if the doctor says it, then it's true. If the doctor doesn't say it, I don't have to be worried about it. But it was probably my mid to late 30s where I really understood that I had to be a partner in my own health care and that I had some agency and power around seeking out health care that was appropriate for me. And not everyone has reached that point. And again, it took me to my 30s to get there myself. And I often talk with folks, whether my own daughter or others, and what happened at your doctor's appointment? And it's a quick appointment. Unfortunately, our healthcare system is such that we are trying to turn over several patients in a very short period of time. And the doctor said A, B, and C. And for me, I always have lots of questions, and I'll say, well, what about this? Well, the doctor didn't say that. Well, why didn't you ask that question? The doctor is seeing so many patients with a very short window of time. And so I guess any strategies that we can put in place to help women and everyone, but since we're talking about Black maternal health, understand here are some important questions to ask, and that it is okay and in fact necessary to kind of be your own best advocate, and not everyone has those tools. And so whatever we can do to help women in particular develop those tools, I think is really important, especially in the context of, we know we live in a racist society, we know that it's a patriarchal society where women are often silenced, and when you add the intersections of race and language, they may even be more silenced if it's a woman of color, or an immigrant woman, or a woman who does not speak perfect English, a woman who may have less education. I mean, you add all of these things, and then we see the results. And so is this something in terms of this group appointments, or just, maybe it's not doctor's appointments, but whatever we can do to kind of create these safe spaces for women to kind of share their experiences and understand that they too are powerful, and that their voices matter, and that they can and should and must be partners in their own health. Is that something that you're exploring at the commission, and something that you're exploring with the collaborative?
So I think at the commission, the one thing that we do after the women have their infants, their babies, is the Community Action Network. We just had a celebration annual gathering this summer at Codman Square, and one of the things, a theme that came across the different tables that I sat with was the fact that these moms, many of them were young moms, but there were also older moms that were part of this group, that they got out of it was this sense of community and skills development and tools to do that self-advocacy. So they were going to the State House, and their stories and being able to find their voice and to tell their stories was very empowering. And so I know through the CAN, I do think that they help them with navigating care and being able to ask the right questions in those postpartum visits and your well baby, your well child visits. And so those are the sorts of things that happen after the pregnancies through the Community Action Network and in between pregnancies. And I would love to have you come. Yeah. Any of the counselors are welcome to come to one of those CAN meetings, because it is pretty powerful, because the women are the ones that are driving the agenda for us to help and support them.
Wonderful. Any thing that the collaborative is doing around the bringing folks together around building social capital and capacity to be able to advocate for themselves?
Yes, that's exactly what the Reimagining Healthcare forums are about, is how to be an advocate for yourself, how to engage with your doctor and with government to create change. So that is part of what we do. And there are other organizations around the city that specifically focus on Black women's wellness and maternal health, actually nationally, but certainly in Boston too. So that is our goal. In addition, we're looking to see if we can create other things and leverage technology. So we know a lot of places provide online documents and tools, so we're looking at those and identifying which ones will be helpful, see if new ones want to be created, and what's out there as far as apps that can help mom or online forums where they can talk. Although we tend to prefer in-person relationship-type connections, we know that a lot of people are using technology too.
All right. I'm thinking back, I was doing community organizing work, it seems like a lifetime ago, and one initiative that it was the organization that I worked for at that time and Boston Medical Center, Healthcare for All, and there was this partnership that we formed called, and it was to provide support and care for families of children from birth to 5, recognizing that brain development was happening at that time, and infant mortality was still a concern, and how we could really support families who were giving birth to these newborns, and it was called Connecting the Dots for Boston Tots. And one of the things that we did is we delivered welcome baby baskets with not just kind of the diapers and the ointments and the things, blankets, baby blankets, but also the resources and the information that families would need to understand, this is a journey now that particularly if it's a first-time mom and dad, that you have like a lifetime to go with your child, but here are some resources, particularly in the first 5 years. Any kind of efforts around that either the commission or the collaborative is doing to interface with moms, particularly Black moms as they give birth, to make sure that there's that follow-up happening, beyond the doctor's visits that they will go to with their baby, but in terms of that support system and creating the support systems that we're talking about.
So that I referenced the Healthy Baby, Healthy Child program. So that's the home visiting program, and we can give you some more information about that, so you know the types of services. But that is based on a home visit model. Excellent.
Yeah, right now the collaborative is not, but I love that idea of a welcome baby package and what's included.
Yeah. So here in Massachusetts, the rates are better than in the rest of the country, yes, but we still have kind of the gap between Black women and white women. What strategies are underway that we need to know about, or should be underway, because maybe they don't exist, to really pinpoint and target Black women when it comes to these disparities that we see? So, and I ask this question because often in Boston and in Massachusetts, we focus on things that help. They use the term, the tide will lift all boats. And what I'm trying to get at is that you need kind of targeted intervention for certain groups. It's not enough just to say everyone will have better access or opportunity, but how, when we realize that these gaps are in place, how we get targeted intervention for these groups. And so while we see that Massachusetts may be doing better compared to other states, we still see these persistent gaps when we kind of peel back the onion, look at different ethnic groups, we look at, whether language could be a barrier, we look at poverty, and so I'm really looking for something that is targeted, getting at these individual, racial groups who may not be benefiting from the approach of we're lifting all boats. Is that clear?
Yeah, so this is definitely the focus of the Healthy Start Initiative funds. We actually, unfortunately, our grant was cut by nearly 50%. This is a federal grant and they made it competitive this go around. And our working hypothesis was that it was cut to provide additional resources to other parts of the country. Thankfully, we were competitive, And the grant, I believe, is at around $1 million now. It used to be well over $2 million that we received from HRSA, and that's specifically looking at Blacks in the neighborhoods where we have the highest infant mortality rates. So the health centers that compete, and the Boston Medical Center is part of the program too, they compete for these resources, and so Bowdoin Street, Codman Square, Mattapan, Whittier Street, and Boston Medical Center's Teens and Tots Clinic are the service, the delivery point for these services. And that's specifically focused and targeting our resources and attention on Black infants and Black moms.
Yeah, so I think grant support is important for all of this, and our work at the collaborative is FUBU. It's for us, it's by us. And we're looking specifically at what Blacks need for wellness in general. We're working on a tool to do an assessment that would include the social determinants. That's a little different than what's currently being promoted, and a little bit more broad in scale, but definitely more specific in both application and recommendations. So again, it requires funding, but I think it will make a difference in how we can approach things.
Right. And I assume funding will be important for a lot of the initiatives that we want to move forward with. Just as I wrap up my round of questioning here, I'd be interested if there were 3 maybe concrete recommendations that are not related to funding, because I know obviously we need more resources to tackle these problems, but if you could offer 3 recommendations for kind of closing the gap when we're talking about Black maternal health, what would they be? 3 to 5, if you have them, that we really should focus on in the next 1 to 2 years to begin to close this gap. If you each want to offer your recommendations.
I can start if you'd
Okay.
like, Dr. Reed. So I think some of it, we talked about it this morning, and you hear about it when you look at the resources that we have in the city, and we are fortunate that we have extensive resources both on the clinical side, on the public health side, and in communities. But I wonder if there might be an opportunity for the mayor, the city council, our clinical partners to do some kind of inventory to help us better map out where these resources are, and to identify if there are any specific gaps across the lifespan, from birth to aging. And I think that is something that I don't believe I've seen. And knowing what the resources look like and where there are gaps might help us in figuring out, are there solutions that might not require an investment of resources, and maybe it's just better coordination, and how do we mobilize community to address some of those gaps with us?
Thank you.
2 things come to mind. First, I think as far as early identification of mental health issues, we have electronic records now, and a lot of things are templated. It would be very easy to put in questions that providers would have to ask along somebody's pregnancy path, and that when they finish their obstetrical care and come back to primary care, that the questions continue to be asked, that the ball doesn't get dropped. So I think that would be an easy fix. The other thing is, we always think about, can we do a volunteerism thing where there is no cost? And I don't know if there are organizations now where experienced moms can mentor non-experienced moms, but that might be something worth looking around to see if that's a resource that's available.
I guess, and my final questions or thoughts, as I wrap up my questions here. We talked a lot about supporting families, the moms themselves, giving them the tools, the right questions to ask, the support systems, the services. What can we do with the providers themselves, or just around racism and addressing implicit and explicit bias? At the earlier hearing, and thank you for your participation on that panel, Monica, one of the panelists, I can't remember who, talked about training for doctors and healthcare providers. How do we, and acknowledged that, the vast majority of people in our healthcare facilities are doing good work and are working hard and don't believe that they are victims of implicit bias or that they kind of perpetuate that. But in fact, we know that this is happening. And so what more, beyond helping the family, the moms themselves, what can we do in terms of the providers, the healthcare providers, whether doctors, nurses, practitioners, to remove bias? And are there trainings underway that you can speak to that are dealing specifically around prenatal care, Black maternal health, in terms of bias with trainings for providers?
I don't know if there is specific around maternal health, and that would be the recommendation. And it doesn't have to be long because it's building on existing trainings that people are receiving around implicit bias and cultural sensitivity as opposed to cultural competency. So I think there could be mini modules that could be implemented for providers just to reinforce. And just like every year they might have to do conflict of interest statements, it'd be good to do updated modules about current trends in this topic.
Because I worry that, we will translate materials into another language and then we think that we've done something when in fact we still may be operating. I think it was you who mentioned the stereotypes and myths that people have when it comes to Black women. And I know I mentioned it in my opening statement around being kind of superhuman, being very tolerant of pain. And so oftentimes our issues are dismissed, and I think you're right that we need an ongoing approach to kind of tackle these biases. So yeah, I would be interested in any concrete recommendations moving forward, but I do want to be mindful that I've asked several questions and want to give other counselors an opportunity and then hopefully can follow up with each of you individually. I do appreciate your testimony here and all of the work that you're doing. Thank you so much.
Thank you,
Mr.
Councilor Janey.
Chair.
Of course. Councilor Flynn?
Thank you, Councilor O'Malley, and thank you, Councilor Janey, and to the panelists for your informative presentations today. I just had a couple comments and questions. I know it's not a level playing field for African-American women. I'm wondering, is there a disconnect between our hospitals, colleges, universities, and maybe healthcare centers and our patients? Are we providing our patients enough support and care from these great institutions, these great hospitals, colleges, and universities, or is there a way for them to play a more important and engaging role, especially as Councilor Janey mentioned, doctors can be over, you can have an appointment in 10 minutes and you don't get an opportunity really to ask the right questions, but is there an opportunity for someone to kind of also step in and work closely with the patient and the hospital and the healthcare center so the patient knows exactly what the issues are, but also a path forward for the patient as well?
I think there are efforts to provide navigators and case managers to help support patients. So I think they are trying to do something in that effort. I think what has happened in healthcare is there's been so much consolidation and we have these mega institutions now that it still becomes a challenge for individuals to know how to advocate for themselves in them. And even when they do, they sometimes feel that they're not being heard or sidelined. So understanding how then to go to the next level, whether it's through an ombudsperson or a facilitator to help smooth communications, is a place where I think we could do better. But there's years, decades, centuries of history here where trust has been lost, and so it's about rebuilding trust too. I will always tell you that I think we need to see more diversity, so that people can feel comfortable and have somebody in the service area that looks like them, that they feel is representing them.
I agree. I think there are examples when we visited community health centers. I'll talk about that experience in the city, that there are several health centers that we've been to that try to help their patients better navigate things beyond just the clinical services by, for example, by bringing housing specialists on site there on certain days of the week, because that's something that they know that, you know, especially in the community health centers, that the patients are grappling with, or the displacement and housing challenges. There's some health centers that are doing a lot of work in the space around transportation and really coming at it head on in terms of these barriers that make it difficult for their patients to access care. So I think there's always room for improvement, but those are a couple of examples that I can think about that we've seen in our health centers.
Do we follow up with the mothers that deliver a child? Maybe the child has a low birth weight, but do we follow up with that mother for a period of time, maybe 10 years, knowing that there's maybe a complicated pregnancy or a low birth rate? But do we follow that mother and child over several years to make sure that that mother gets the medical care she needs, she gets the social service assistance she may need? And is there a way to track that mother and child to make sure that they don't get off track, but they do get the needed services that they need?
So I can speak to our program, the home visiting program, Healthy Baby, Healthy Child. I can double check, but I think it goes up to the age of 3. I'd have to defer to Dr. Reed. If you have a low birth weight or preterm birth, I'm not sure how long you follow.
Yeah, I don't think they get followed that long, but certainly with the new ACO models that are accountable care organizations that are looking to provide wraparound services for continuity, there is improvement in that area, and of course, we're hoping that that's going to have a big impact. We'll have to see. But I think there is a need for that. Part of, again, is the design of the healthcare system, where you go from the obstetrician to the primary care to the pediatrician, so different people are overseeing different things, unlike in the old days when there was a family practice doctor who took care of the whole family. So now we have a communication issue to make sure that people are communicating among each other and tracking this. When somebody re-enters the obstetrics, they ask about previous pregnancies. So that'll send up a flag if they had problems with pregnancy or with a low birth weight baby. But you're right, that low birth weight can define somebody's entire existence into adulthood and how well they'll achieve and succeed in life.
Thank you, Doctor. And I think my final question, but before I ask it, I just want to say thank you to Monica and to the doctor for your incredible work on this important issue. And I think public health is doing a lot of great work, a lot of great outreach. So I just want to acknowledge that and say thank you. And Doctor, I know you mentioned wraparound services, wraparound programs. You know, maybe there might be a role for the Boston Public Schools to play as well, knowing that if a child has a low birth rate and there may be complications with the pregnancy, tracking the data, but tracking the mother and child to make sure that that child as well gets the public school services that they might need. I'm not saying they do need them, but they might need them due to a low birth rate as it relates to maybe other health complications along the way. Is there a role that we know for the public schools to play some type of meaningful role on this issue?
Yeah, this is where resources would be good in indexing resources, because there are organizations like Higher Ground who do work in the school system to identify at-risk children and help support them. So yeah, I think that would be perfect.
Thank you again for your leadership, and I just want to say thank you to Councilor Janey and Councilor O'Malley as well for tremendous work on this issue.
Thank you, Councillor Flynn. Panelists, we'd like to ask you if you wouldn't mind just staying a couple minutes, but I'm going to take, since we only have 2 individuals who've signed up for public testimony, I'm going to ask them to give testimony. There may be additional questions from the panel, and then if anyone else who hasn't signed up and would like to speak, we'll take you in the second round of public testimony. But for initial public comment, I'd like to invite Emily Anesta from the Bay State Birth Coalition and Christina Gebel, a doula, to please join us at the 2 standing podiums up here. And then those are the only 2 individuals who have indicated they would like to testify. If anyone else would like to, please sign up on the sign-up sheet to the back left. But
you want us at these podiums?
yep,
Okay,
Emily
great.
and Christina, or Christina and Emily.
Is it a time limit of 2 minutes? Is that right? Or
We'll say 3, if you can.
Okay.
Brevity is the art of wit, so but 3 or 4 minutes will be
Okay.
fine. I don't time you.
no problem. Hi, my name is Emily Anesta. I'm a Boston resident and one of the founders of the Bay State Birth Coalition. Boston is a great city for medical care. We have, as was mentioned, we have top research hospitals, no shortage of providers and institutions to save lives when we have a medical crisis. However, pregnancy and childbirth are not medical crises. Pregnancy is a normal state for the human body, and childbirth is a normal physiologic process. While in some cases medical intervention is helpful or necessary, overuse of medical interventions in childbirth has not led to healthy mothers and babies. So I'm here to say that we need policies and investment in expanding access to midwives, growing and diversifying our midwifery workforce, and establishing freestanding, independent, and midwife-led birth centers, such as the Neighborhood Birth Center Project, which is a project led by Black women who are Boston residents looking to establish a birth center in the city of Boston. While Massachusetts is generally a healthcare leader, we rank in the bottom 1/3 of states for midwifery care integration, despite the evidence of significant benefits from the holistic, the relationship-based midwifery care. I was hearing you, Counselor Janey, talk about short appointments. When you see an out-of-hospital midwife, a typical prenatal appointment can be up to an hour long if the client wants it. And you have continuity of provider, extensive postpartum support, and so forth. So that care, the benefits include fewer neonatal deaths. This is just when you integrate midwives into the system. Fewer neonatal deaths, fewer preterm births, fewer low birth weight babies, fewer C-sections, and higher breastfeeding rates. Last month, the Boston Globe published an article titled, "Rates of Maternal Mistreatment in the U.S. are high across the board, especially for women of color." And this article showed that 1 in 3 women who give birth in a hospital experience mistreatment and abuse by medical providers, including being yelled at or scolded, or being ignored and refused assistance. An excerpt from that article, which was referring to a study in The Lancet in 2016, said, "Maternity care that is too much too soon, including unnecessary cesarean sections, induced labor, and routine episiotomies, may cause harm, raise healthcare costs, and contribute to a culture of disrespect and abuse. Midwifery practices can help to cut down on some of these unnecessary interventions and also improve mothers and babies' outcomes, yet many women, and in particular women of color, lack access to midwives." That was from the Globe article last month. Thank you.
Thank you very much. Appreciate it, Emily. Christina?
Yep. So my name is Christina Gable. I work for the March of Dimes Foundation here in Massachusetts, but I'm coming here today as my role as a private citizen and also as a birth doula. So I'd like to address some of the comments that were brought up earlier that I think I can try to help answer. First, I want to say that Dr. Meadows sends her regrets. She's unfortunately not able to come due to a last-minute issue, but she has sent in on email her testimony. So I wanted to start by saying it was asked earlier whether these resources have been mapped. So Rose Molina is a provider in the Boston community working with Anna Langer at Harvard to map these resources in the community. They're literally doing a needs assessment through Ariadne Labs of which resources exist for moms in Boston. I also would like to address the quote, low numbers of maternal mortality in our city. yes, those data are absolutely true. But I want to say that those data are really only the tip of an iceberg, because what we are seeing is a rise in severe maternal morbidity. And those are women who experience illnesses that are pregnancy related that can affect them for the rest of their life. So what could happen is they might have preeclampsia in their pregnancy and go on to have hypertensive issues after pregnancy that can very much threaten their life. Another one is gestational diabetes, which puts them at risk of type 2 diabetes after pregnancy. And in one of our medical centers, that's working to improve screening after pregnancy for diabetes because there's so much at risk, only 30% of those women are getting followed up screening for diabetes once their pregnancy and birth has happened. So we can easily see how, yes, we don't have as many women dying, but we do have a lot of women with chronic conditions, and there are disparate rates for that by race, ethnicity. So I want to hold that up. Asking what other cities are doing. So New York City has started asking questions on a statewide level, but also, I'm sorry, not on a citywide level, specifically about consent and birth trauma and disrespect in the maternity care system. And that's through their pregnancy risk assessment monitoring system, which we have one here statewide. New York City has its own because it's quite populated. But they have actually developed a series of, I want to say, 5 or 6 questions that get to this idea of disrespect and trauma in the maternity care system. So I'd like to hold that up as a possible solution. It was asked earlier about group prenatal care. And my colleague at Centering Pregnancy, which Centering Health Institute is headquartered here in Boston, we're very lucky for that. We have 5 group prenatal care sites within the Boston limits, one at Boston Medical Center, one at Bowdoin, one at Dimmock, one at Mattapan, and one at Whittier. So actually we're quite lucky in that sense, and March of Dimes is also looking to spread group prenatal care at additional sites here in Boston. I also want to speak to what was brought up, implicit bias training. So March of Dimes right now has awarded a national RFP to Quality Interactions, which Dr. Betancourt is, I think, president of, if not their head PI, to develop implicit bias training specifically for the perinatal period. So to your point earlier, yes, implicit bias training always in any part of healthcare is useful, but we also need to focus specifically on what that looks like in maternity care, because many Black women are getting ignored and neglected, even when they know something's wrong, and even when they've said something's wrong. And that's what's particularly troubling, and what Representative Liz Miranda has been so vocal about. It's not that women don't know, it's not that they don't speak up, it's that we're not listening. And that's a huge problem. It was asked earlier about data linkages and if we follow women. So we're really lucky here in the state of Massachusetts to have a system where we can link hospital data when a woman is pregnant to discharge outpatient data. And we're one of the few states that really has those linkages set up. But they're expensive, and it takes a lot of time and resources to do that on a state level. So I would say, committing more resources to data linkages is a way that we can follow these families well into early childhood. And then finally, my last point is I'm coming here as a doula today, and not because I want to promote that doulas can solve all these problems, but because we have a unique opportunity with doulas, and that is, right now, for better or for worse, the way that our maternity care system is, it's very high volume. A lot of women do have choice around where they deliver, but you might go in to deliver, and because of the way that group practices are set up, or on call and shifts and so on and so forth, you might not have the provider that you saw in prenatal care. You might have 1 to 2 nurses. And I think what doulas do is just introduce more autonomy into the birth experience, that you are choosing someone from your community who understands you culturally, who shares your same race, language, dialects within those languages. There's a huge piece to be said that home visiting is really wonderful and it's really great and we should expand that. But where is public health at the point of birth, as one of my colleagues says? What is the public health call for the birth experience? And that's where I think doulas can be really helpful. And we do have a piece of legislation in our state, which is being championed by Liz Miranda and many other legislators. And I just want to hold that up because I would like to see a doula for every mom who delivers in Boston. I really would. And I would like to see those doulas not necessarily be me, but come from the community, because I think there's a real opportunity there for a career ladder, but also for workforce development. And that's why Representative Nika Elugardo was so interested in our bill, because she sees this as a pathway for women in her constituency to really have jobs and become more specialized in lactation and childbirth education. I mean, all those things, you know. So there's career opportunity, but there's also community opportunity. And should we put the burden on community to solve these issues? No, we shouldn't. But we should look to the community and draw from the community for the solutions. And that's where I see doulas being a big part of that. I'm happy to answer any questions. So.
Thank you very much.
I do have a question.
Please,
Yeah,
of course.
thank you so much. I do have a question. You mentioned as part of your testimony this notion around consent.
Yes.
What did you, can you
Yes.
expand upon that?
So there's a lot of kind of rhythms that we've fallen into the maternity care system. Some are out of convenience, some are efficiency, some are evidence-based, some are not. Some are medically indicated, as we heard earlier, some are not. But what we as doulas see a lot is patients not being offered the consent for things that are considered routine. So for instance, like doing a vaginal check to see how much someone is dilated, that can be a very traumatizing experience for someone who comes into the delivery room with a history of sexual assault and abuse or rape or other traumas. So saying simple things like, are you okay with me doing this right now? Or I'm about to do X, Y, and Z. Are you okay with that? You know, I see that quite a lot in practicing with all demographics of women. I want to be clear that this is a systems issue. It disproportionately affects women of color, I truly believe, but I've also seen really horrifying disrespect among women across the board. So, you know, what does a doula do in that situation? She witnesses what happens. Because then when women come to say, you know, I was mistreated or something happened to me and I don't feel like I had my consent, that doula is another witness in the care system that can then say, yes, I saw that too and I perceived it the same way. You know, so we have to have these systems in place where women can then go back and process their trauma, mental health being especially important there, but we also have to have systems in place where we can elevate those experiences and say, yes, this is happening in our maternity care system. And I think doulas can serve as witnesses to some of the things that we're seeing and that are happening. So.
Thank you. That was helpful.
Thank you.
Thank you very much, Christina. Appreciate it.
Thank you.
And there is just one more, which I will allow. If we could just ask you to please be as pithy as our prior two speakers, but Jessie Colbert would like to offer some testimony as well. Jessie is with the Mass PPD Fund. So welcome.
Hi, I'll
Thank
be
you.
very brief,
Thank you.
and you just introduced me. As you said, I'm with the Mass PPD Fund, and we're a new nonprofit working to raise awareness and increase services around perinatal mental health in the state. And I also serve with Rep. Miranda on the Postpartum Depression Commission. I was really happy to hear in everybody's remarks on the mental health side, because that is our focus. And as with many of these other issues, the disparities issue is more prevalent on the mental health side, and we also see a lack of services on that side. So we're working on that. And of course, it's not just postpartum depression, but as Christina mentioned, the disparities issues around birth can often result in trauma, and then you're dealing with other mental health issues around that. So we're brand new, but we have a couple of projects in the city of Boston. I was also happy to hear the counselor mention the importance of groups and social support, and we're looking to build some partnerships. We have a couple of projects around that. We we've also worked with the Healthy Baby, Healthy Child program, Postpartum Support International, and working with some of those clinicians coming to a national training. And I'd also just like to encourage working in partnership with some of the leaders at the state level and the national level are actually right here in Massachusetts, and I want to draw your attention. There was a Globe magazine article around medical mistreatment and African American women, and a number of the leaders in Massachusetts on the mental health side wrote a letter to the editor around let's not forget the mental health side. I can pass this along, and those are leaders that are very active and looking for partnership opportunities with the city to really make a difference. Thank you.
Thank you very much, Jesse. Appreciate it. I believe that's all we have for public testimony. If anyone else would like to testify, please sign up, and we'll have you after the conclusion of this panel. And I'd like to turn it back to Councilor Janey for any questions for the panel.
Yes. I'm just grateful for the opportunity to have this conversation. You know, I recognize, too, that this issue starts long before a woman is seeking prenatal care, and it becomes this vicious cycle. So if you were a child who was born with low birth weight, who had different health challenges because of that low birth weight, and then now you're an adult who's having your own child, it just becomes this vicious cycle. So obviously there's a lot more work that we need to do to not just decrease mortality rates for Black women, for all women, but we really have to make sure that we're pinpointing and targeting certain populations to make sure that we're doing more for them and providing the needs, the services that they actually need. You know, recognizing the intersection of womanhood and Blackness, and as it pertains to doing more for all, which is the lifting the all boats model. You know, I'm always mindful that that rising tide, if you don't have the supports that you need, if you don't have kind of that wraparound help and circle, that rising tide can tip your boat over. So it's not enough to just say that they will lift all boats, but you need the actual supports in place. So I hope that we can continue these conversations. That's okay with you, because this for me has been a wonderful opportunity to learn more, and I thank you, Dr. Reed. I remember the meeting that we had here and coming out to speak to your group. So for me, learning more, and I'm a mom, I'm a Black mom, and I've been through, and I guess, a high-risk pregnancy myself. But there's a lot more as elected officials, so I want to take off my Black mom hat and use my elected official hat to really kind of target some concrete things that we can do in the city of Boston that will help us address not only the implicit bias, but the explicit bias, and also arming Black women with the tools that they need to ensure that they will get the health care that they deserve. And so I'm grateful for this opportunity to partner with my dear friend and colleague, Councilor Matt O'Malley, as well as the amazing panelists. So thank you for your work every day and for being here today, and I look forward to continuing this work, because clearly we've got a lot more work to do.
Indeed. And I would just add to that, would be my recommendation as the chair of the committee, and for folks who are sort of watching this or are not as familiar with this process, when the calendar year ends, our legislation ends. So it would probably be unlikely that there would be action taken before the end of December, the middle of December, for follow-up. So, Councilor, I would think it would make sense if perhaps we agree to refile this legislation in January, and rather than doing a hearing again, go right into a working session. And I would even argue that I think it would make sense to have a series of working sessions in community health centers. I know one thing you've done exceptionally well is bring the council to the community. While this is a great building and sort of centrally located, sometimes it's better to meet folks where they live, literally and figuratively. So perhaps we could do that, work with you, work with other panelists, but most importantly, work with all the advocates and interested parties here, because there is a lot of work to do. And just talking about the issue makes sense. I had no idea of these statistics before we started doing some work, and there was a fair amount of media on it, which is good, obviously, but just having these conversations, not losing sight, as some of our panelists had mentioned, about the mental health aspect as well, how that's so important to it. Dr. Reed mentioning fathers and including them in the conversation is something that's vitally important as well, and I think we can be a safe space to sort of talk about that, look at some best practices and figure out some strategies going forward. It could be as simple as having a resolution in support of some of the legislation offered by Representative Miranda or some other, obviously Congresswoman Presley, supporting her efforts at the federal level, but we can make some very minor policy changes that I think will be impactful. So this is something that's incredibly important to me, I know to you and to all of us, so it's exciting and hopeful to get to work on it. So I appreciate that. Did either of you have any closing thoughts or questions for us as the board or members of the council?
Thank you for inviting us
Of
to
course.
be here, and it was wonderful to hear from the others who testified as well, and happy to continue this work.
That's great. Thank you.
Likewise, I mean, I think we'll look forward to continuing to do those series of working sessions and bring in other partners who are doing this work in our communities. So thank you.
No, thank you very much. And we have one more. This person has indicated they would like to testify, Lee Graham. Lee, if you could please join us up here. And then Lee will be our final person offering testimony unless anyone would like to say otherwise. Speak now or forever hold your peace. Seeing none, Lee, the floor is yours.
Thank you. My name is Lee Graham, and I work with Dr. Rose Molina at Ariadne Labs. So I just wanted to thank the person who mentioned the work that Rose is doing and tell you just a little bit more about some of the work that Ariadne is doing. We are on I'm a member of the Delivery Decisions Initiative, and we work to improve childbirth outcomes in the U.S. We do a lot of work in health systems trying to reduce cesarean section rates, as well as increase autonomy for birthing patients and communication and some of the issues that you guys really talked about. But one of the new initiatives that I'm actually working on at Ariadne is to collaborate with cities around what cities need, the tools that folks like you need in terms of data and evidence and process and capacity to really be able to respond to maternal health issues like we've been talking about today. So that's something, it's a brand new initiative. We've just launched it, but it sort of dovetails nicely with the work that Dr. Molina is doing here in Boston, and we're really trying to think about what do cities as platforms for improving maternal well-being, what do you guys need to really be able to take action around this issue? So would love to keep talking, and just thanks so much for having this hearing today.
No, thank you very much, Lee. And we have sign-in sheets from most folks that includes email addresses, so we will do a committee report, perhaps not as early as this week, but follow in the next subsequent weeks. If you would like to stay involved, please leave your email on that sheet if you haven't left it with us already, and we'll make sure that everyone is kept in the loop for subsequent working sessions. Again, likely it would be after the first of the year, but I think just knowing my colleague and I were excited about getting things really planned and working ahead of time. So thank you all for that. I have no further conclusionary comments. Thank you, Councillor Janey. This is the City Council's Committee on Healthy Women, Family, and Communities. We are discussing docket number 0396, and the hearing is hereby adjourned. you.